Thanks for joining us. I'm your host, Raquel Faria. I am a doctor in internal medicine at the Centro Hospitalar Universitário Santo António in Porto. Today, I'm joined by Professors Murray Urowitz and Ronald van Vollenhoven from the Lupus Academy Steering Committee. So today we are going to discuss the 2024 ACR guidelines for screening, monitoring, and treatment of lupus nephritis. We'll look at the key changes, clinical implications, and practical considerations for both lupologists, nephrologists, and other healthcare professionals involved in managing lupus nephritis. It was first presented at the ACR Converse meeting in November 2024, and the paper was just published last 24th March. Murray, Ronald, welcome, and thank you so much for joining us today. Let's start with a brief insight into the significance of lupus nephritis and why there has been a decade-long gap since the 2012 ACR guidelines for the management of lupus nephritis in both adult and pediatric patients. Ronald, a lot changed. And what do you think that were the main drivers to this update on the guidelines?
Well, I totally agree with you, Raquel, that it was time for these recommendations to be updated because so much has, in fact, happened. I think the understanding of lupus nephritis, of the consequences of it for the long-term outcomes, and also of the pathophysiology have, of course, advanced. But the most important changes have actually been in the treatment possibilities. I think when the recent version of the ACR recommendations or guideline were published, it was still standard to consider high-dose cyclophosphamide, but the Urolupus trials had already shown that lower dose cyclophosphamide, according to that schema, were equivalent in efficacy, so that was already happening. And of course, the importance of mycophenolate as a treatment option at least the same level of cyclophosphamide, possibly in some instances better, had also emerged. So that was already known, but it was still, I think, being absorbed by the collective of rheumatologists and nephrologists. What has come in addition since then, and which is of course very important, has been the approval of belimumab as an additional treatment option for patients with lupus nephritis, and in addition to the use of mycophenolate or possibly low-dose cyclophosphamide. The approval of voclosporin as an additional treatment option that was added to mycophenolate, and that those were actually formally approved by regulatory authorities. In addition, a lot of publications about other forms of combination therapy where indeed calcineurin inhibitors, especially tacrolimus, were studied, not leading to a formal approval, but certainly in the literature. And also increasingly the use of anti-CD20 monoclonal antibodies. Of course, for many years, rituximab was used, again, not formally approved, but certainly used and studied. And very recently, and actually coming after these recommendations that we're now discussing, the other anti-CD20 monoclonal antibody, obinutuzumab. So a lot of things happening. And of course, these developments don't happen on one particular day, but they're over the course of time, and leading certainly to greatly insights into the best treatments for lupus nephritis, and now also changed recommendations.
And we are going to discuss it in more detail. Murray, do you have anything to add? What do you think there are more drivers to these guidelines?
I do. So Ron mentioned new drugs and newer concepts of pathogenesis. What I'd like to stress is the newer focus on disease modification. We're going to come back to that later. And an important aspect of disease modification is not only control active disease, but prevent damage. And it's been highlighted over the last number of years that we've been too lax in preventing damage, especially in the kidney. And so we've sort of gone along testing these new drugs and adding one drug to another. In the meantime, as the drugs have not given us 100% improvement, we've had loss of nephrons. And so, yes, eventually you get the patient under control, but they've ended up with kidney damage. And I think that concept of preventing damage and what do we have to do with our treatments to prevent damage has become central, especially in lupus nephritis.
Thank you. So let's now look at some of the key recommendations of the ACR 2024 and what do they mean in the clinical practice. The guideline summary provides 28 recommendations and 13 good practice statements looking at screening, when to perform a kidney biopsy, treatment, special emphasis on the triple immunosuppressive therapy are going to be there. Let's dissect some of the challenge we still face with lupus nephritis and how these guidelines may or may not help us meet those. So Murray, it's not new that early preclinical diagnosis of lupus nephritis is crucial for prognosis. What do you think are still the main barriers for early diagnosis, mainly on lupus nephritis? And how do you think that these guidelines help us overcome that?
Yeah, so I think that, people have had in their minds, oh, lupus nephritis occurs in 40 to 60% of patients. And if my patient comes in and doesn't have lupus nephritis at presentation, they have severe arthritis and skin, I'm off the hook, and all I have to do is treat the nephritis and the dermatitis, the arthritis and dermatitis. And that's folly, because even in those patients, if you see them 2 or 3 months later, they may have very significant nephritis. So we have to alert people to be on the lookout for nephritis, even if it doesn't initially present. And then the other thing that we've really learned in the last little while is that the major screening for nephritis is, of course, proteinuria. And not everybody with nephritis will initially have proteinuria. They may have active nephritis, but not proteinuria. So that's another warning sign to people. Don't feel you're off the hook if the patient doesn't initially present with proteinuria, but continue to look for it. And I think the guidelines are making those suggestions in a number of occasions. How often you have to repeat urine testing and anti-DNA and complement studies to ensure that that nephritis is not present. So that's the first thing. And we've got to alert the treating physician that they have to be on the lookout all the time. And the second thing is, and I've mentioned that already, is that we've learned that even in people who don't have proteinuria, when you are testing them, 20% could still have a positive renal biopsy for disease activity if taken. So we can't rely on proteinuria as the definitive diagnosis for nephritis. So be on the lookout continuously. And you see there's some guidelines now. If even if the patient has not had nephritis or proteinuria, you should repeat the study at least in 3 months. If they've had their urine studies every 3 months, if they've had nephritis, you should do the urine testing every single month, at least, right? And if they've never had the nephritis and you've tested them for a few times, still every 3 to 6 months you should do the urine test. So these guidelines are saying to us, stay alert, because if it's negative when you first see the patient, you're not off the hook.
Thank you. Ronald, do you have anything to add? Any thoughts?
No, I completely agree with everything that Murray just said. And I think the ACR guidelines does a good job of pointing out the importance of this kind of monitoring. It's a teaching point that the renal involvement, along with hematological, are the lupus manifestations uniquely that the patient may not realize themselves. Mm-hmm. If the patient has a skin manifestation of lupus or arthritis, they can usually tell you that. It won't go unnoticed, but they could go around with significant cytopenias or with significant renal disease without knowing it. So we as physicians need to be aware of this. And the ACR guidance documents are often formulated very cautiously. They will say that they recommend something conditionally. And this has to do with the methodology that they use. But I think when they recommend something, it's nonetheless based on pretty strong evidence. And even though they say it's conditional, I think we can say that that's really, at this point, a very strong recommendation that we should all follow.
Thank you, Ronald. And another thing that you were both mentioning, but not clearly, and Marie, you said it several times, if the patient does not have kidney involvement when the first presentation, it is implicit that it's more common on the beginning. But from your experience, what was the longest lupus nephritis on the evolution of the disease that you have seen?
You mean occurring for the first time during the course of the disease?
Yes.
Yeah, so generally speaking, when it isn't present early, it does manifest within 3 to 6 months. But we've seen the odd patient, 3-4 years into the illness, where they have never had nephritis known to us.
Yes.
Right.
Yes.
And now they manifest it. And those are the people whom you biopsy, and you see not only active disease, but you see signs of damage. So we think that those people have had non-discernible to us nephritis for a number of months or years, and now they're manifesting it. So it could happen anytime, most common within 3 to 6 months, but it occurs sporadically at longer intervals as well.
Do you want to comment, Ronald?
Well, I want to add that I personally may have certainly seen patients presenting with nephritis after 2 or 3 or 4 years, perhaps not longer than that. And of course, we must be very aware of this as physicians. I don't think we should scare our patients into having terrible feelings about their prognosis that something will happen. It could also not happen. So I think it's more for us as the physician to be aware and alert, and at the same time giving the patient also the fact that if they haven't developed nephritis in many years, it obviously does become less likely.
Yes,
but as the caution there is, remember, it's recommended that even in those people, every 3 to 6 months, they should have a urine studies.
I do remember a patient that had at first, that we know, lupus nephritis 15 years after the first presentation of lupus. She was mostly skin and joint, and then on the beginning of the pandemic, and which was really difficult, she had several stresses, family stresses, and she presented with a class 4 nephritis, and it was really hard. We all thought that she was safe after 15 years. So it just got stick to my head. It can happen every time. So, Ronald, kidney biopsy. The guidelines also have a say on this. When to perform? Do you think that these guidelines are okay for the clinical practice on the current timing of the first biopsy? What do you feel about what it states on the guidelines, and when to repeat biopsy? And I know this is a hot topic.
Well, there's a couple of interesting points. I think the ACR guideline does a good job on summarizing the evidence and drawing reasonable conclusions. I think the first, they say 2 interesting things about the first biopsy: do it as quickly as possible. So you do want to, really consider the biopsy whenever you see that something is not right with the kidneys, because trying to guess what's happening is really, really hard. And if we guess, we will, draw the wrong conclusion many times in both directions. Sometimes we think it's really bad, and it turns out on biopsy it's not so bad. But unfortunately, the other thing can easily happen, that on the face of it, with the urine maybe not being completely normal, but just having small abnormalities, the patient nonetheless feeling quite well with the creatinine clearance not being changed. We think everything is fine. It turned out to be a very severe nephritis. So that happens. So the biopsy should be done. What they also say in this ACR guideline is that if you, for some reason, cannot do the biopsy immediately, if there's maybe a wait time, there are practical reasons why it will take a few weeks, maybe even longer, and you suspect nephritis, start the treatment with glucocorticoids. I think that's in practical situations important recommendations that does not come in the place of trying to get the biopsy as quickly as possible.
Thank you. Mary, we've had a little discussion about it on one of the last recent clinical cases discussion. And in my head, ideally, we would have a minimal invasive continuous nephroscope to see exactly what's happening to maximize treatment at every time we could, but we don't have it. And so how and when do you think a biopsy would change the treatment decision? Both, not only the first, but the rebiopsy.
So I agree with Ron about the quickly getting a biopsy. Now, let's assume that we're dealing with a patient who is classic and responsive, and at 3 to 6 months, they look like they're heading toward remission, and the proteinuria is now normal. There are many people, including myself, who say we shouldn't get too complacent. A repeat biopsy to confirm response would be very beneficial. Does that happen very often? No. And the reason for that is the nephrologists don't want to do it. They say it's too dangerous, et cetera, et cetera. But, you know, the fact that the proteinuria has disappeared doesn't necessarily mean the kidney inflammation has disappeared. So I like to, if I had my choice, my druthers, I'd love to get a biopsy when they seem to have gone into remission and I'm easing off, say, coming down on the steroid, but maintaining the immunosuppressive therapy. So I think that's important. The second time, of course, is the opposite of that. If after 3 to 6 months, the patient has not responded, then have they changed, or are there other factors that are now operative, like tubular interstitial problems, vascular problems, etc. And so a repeat biopsy in the failed patients after a 6-month period might be indicated, right? So those are two. The second one, the one which has remained active after 3 to 6 months, the nephrologist will probably agree. The first one, biopsying someone who seems to have responded, the nephrologists often don't agree. But for me, those are the 3 ideal times.
Thank you. Let's now have a look at some treatment paradigm shifts between the last one, the 2012, and this 2024 influencing guidelines update. So the guideline was shifted from distinct induction and maintenance phase, and now it's based on a continuous combination therapy approach that simultaneously targets different parts of the immune system. The assurance of hydroxychloroquine and renin-angiotensin aldosterone system inhibitor has a backing treatment, and the prompt, as Ronald already said, the prompt steroid bolus and lower daily prednisolone with rapid tapering, and the triple therapy that is based on belimumab versus calcineurin inhibition, and then adding MMF or low-dose cyclophosphamide regimens that were the previous one. So this changed a little bit. Even the language changed on how this treatment would go. So Murray, what are your insights on this proposal?
I love this proposal because it finally, I think, speaks to what we have now long recognized. If you look at all the classic studies, whether it's mycophenolate or cyclophosphamide, etc., all of them show somewhere between a 40 to 60% response rate in a drug trial. That means 40 to 50% of people don't respond. And if you even take the last one that made the New England Medical Journal, that obinutuzumab study, which is now rituximab on steroids, everyone's very excited. What was the response rate? 46% in the responders versus 33% in the placebo. So what are we saying? We're saying that sequential therapy, adding a new therapy after a failure of the first therapy, only gives you a 60% response rate. And if 40% are not responding, they're all losing nephrons, right? So that's not the way to go. So I firmly believe in combinations therapy at onset. You know, why wait to see if a drug fails and then add another drug? Let's use combination therapy at onset, and hopefully that's attacking the disease from a couple of different avenues might give us a better response than what we're now seeing with sequential therapy.
Ronald, what's your insight on this proposal?
Well, you know, Murray is right, but I do have to say that I don't really like the terminology that the ACR has now codified, talking about triple therapy and double therapy and making it as if that is a given entity, but it's not, because what we're basically talking about is there's lots of different treatments, and where we're gravitating towards is to use a combination that is as powerful, as strong as possible, as soon as possible. And that's what Murray was also saying, that we should really hit this disease hard when we can. But to talk about triple, and then actually the triple therapy is actually glucocorticoids and mycophenolate or cyclophosphamide plus voclosporin or another calcineurin inhibitor or belimumab, or maybe also an anti-CD20 monoclonal antibodies, and you should add hydroxychloroquine and a renin-angiotensin inhibitor. So it's really quintuple therapy with multiple choices at every step of the way. So to me, it's not very helpful to just simply say triple therapy. But having said that, I agree with the principle. And now the question is, of course, and it's going to be a hard question for us in practice, which one to choose. Because that is now, there's now so many options, and which is great. Now, Murray pointed out that the response rates in all these trials are still not stellar. I do have to say that I think that what happens in clinical trials is also, to some extent, there are ceiling effects, because you put patients into a trial, and if they then on the next day decide that they don't want to be in the trial anymore, they're considered a non-responder, no matter how well they end up responding to whatever it is done. So you are never going to get 100% in a trial. But having said that, I do think there's still room for improvement, even with all these very good combinations that we have, and we have to keep on working. And it's also fair to point out that these kind of guidelines, or if they're recommendations or whatever they're called, they're always looking backwards, because they're always looking at what's already in the literature, what has already been demonstrated. Even as they are being written, new data are coming, as the example shows with the obinutuzumab trial that was published, but came too late for the current guideline.
Thank you. You know that probably ingenious, but when I first seen the guidelines, I thought, isn't it supposed to every single patient be on hydroxychloroquine? They are reinforcing this here, but isn't it supposed to? And actually, you obviously remember better than me that only in 2012, it was assumed by the classification criteria that lupus nephritis without extrarenal would be systemic lupus erythematosus. That's one of the things that surprised me on these guidelines. Is it still needed to force to remember that hydroxychloroquine should be that? Going back to this triple therapy, Ronald, do you think that in your patients, in your clinical practice, are you going to implement the triple therapy, whatever it is, in every single lupus nephritis?
Well, the short answer is probably not, because we are still also looking at the individual patient and at particular circumstances in each individual. which could have to do with intolerances, with contraindications, with specific risks. So I think that for all those reasons, we'll probably still have some patients that we do not treat with triple therapy, meaning the glucocorticoids plus mycophenolate or cyclophosphamide plus a calcineurin inhibitor or belimumab or an anti-CD20 monoclonal. But we'll do so in the majority of patients, because in the majority of patients, all other things being equal, that should probably be done.
Murray.
So first, let me clarify, Ron, you're being too hard on the criteria. By triple therapy, they mean hydroxychloroquine, mycophenolate, or a similar drug, and one of the others, like belimumab, voclosporin, et cetera, et cetera. So steroids isn't everyone gets steroid for initial, and that's not counted as part of the triple therapy. So I think double and triple therapy has a meaning. It's those three, 2 or 3. Hydroxychloroquine, mycophenolate, and that's double. And if you add one of the others, that's triple. So would I do it? In theory, I'd love to do it. And what would happen is my patients would get hydroxychloroquine, mycophenolate, and then depending on what the patient has, the third drug would differ. So if the patient had a lot of extrarenal manifestations, it would be belimumab, would be my third drug. If the patient had nephrotic syndrome, probably voclosporin would be my drug, or tacrolimus if I can't get voclosporin, et cetera. So that based on, the patient, the third drug may alter. But would I like to use the 3 drugs up front and try to get a remission early and completely? The answer is yes, I would love to do that.
And how do you think that this could be implemented on the rest of the world?
Yeah, you should have asked me how it will be implemented in my own world. And then my own world, still, there are 2 things. A, the drug can be approved by the approval agencies, and then not funded by the funding agencies, right? And so still we have this barrier which says you can only add belimumab or voclosporin or something like that if the other fails. So we're working at that now, trying to convince the payers to allow it. So I think that's going to be a problem all over the world, that people will say, what, do 2, maybe you'll get a response, you'll save a lot of money. And then cost is a big thing in many places around the world. To have 3 drugs, especially when one of them is a new biologic, et cetera, the cost will be prohibitive for some people. So we're talking in theory now, what's the best approach? And practically, your question is absolutely correct. Practically, how is that going to be implemented? And the answer is with difficulty.
Yeah, and
but I'm glad you asked that. Yeah. So no, I was glad you asked that, Raquel, because we are, of course, in privileged countries, Canada, the Netherlands, many countries where we can use many drugs. The costs are an issue, but they can be overcome. Of course, it's not like that in many other countries. I think what we'll do is we're going to use these drugs, but we owe it to our profession and to our patients worldwide to also investigate more and more how we can use these drugs most effectively, which in part also means that use them maybe not indefinitely. So the ACR guidance does say keep on giving the drug even if the patient is doing well for another 3 years. And then they don't really say what you do after that. And I think we need to investigate that, because there is certainly a possibility that some of these drugs can be used for a limited time. And obviously the manufacturers of these drugs are not going to study that so much because that's not their interest. And we as researchers and clinicians should investigate that more. There's also other aspects to consider. Some of the drugs that are new and very good and have been tested now in clinical trials, and they're excellent, but they're very expensive. And for many parts in the world, it's just not realistic, but there are alternatives that are probably almost as good, haven't been tested so extensively, could maybe be used instead. So that's what is happening and what the profession is going to have to figure out. And with that, I think hopefully we can help more and more patients as time goes by and give them the best possible treatment. even in less privileged circumstances.
Thank you. And Mary, for you first. These guidelines are for both adult and pediatric patients. And what do you think on the application of these guidelines for pediatric patients, taking into account that they need more steroids or not, these drugs on pediatric population? What's your thoughts on? What are your thoughts?
So, pediatric lupus nephritis is maybe even a more severe disease than in adults. So clearly we've got to get that under control. I think, and therefore the approach has to be the same with doses adjusted for weight and size, etc. The major difference is steroids, because the pediatric patient has to go through their growth period, their maturation period, etc., etc. And the steroid hormone has a major impact on all of that. So I think that even though we need to use steroid, the doses and the duration have to be considered very carefully so that we leave the patient in the best situation when this is all over in terms of maturation and growth and size, etc., etc. So steroid is the big red light in the pediatric population.
And Ronald, what about these and the studies on the calcineurin inhibitors on the pediatric patients? So all the studies actually are difficult to be done on the pediatric population with lupus nephritis. What are your thoughts on this?
Yeah, so first my disclaimer is I'm not a pediatric rheumatologist. And I do completely agree with Murray that the pediatric population can sometimes have the most severe lupus. I do sometimes get involved in the care of adolescents with lupus or with lupus nephritis. And I find that is exactly as you were just saying, Murray, that they can have very severe disease that can also threaten the integrity of the organ at an early stage. So they are deserving of very forceful treatment. And there, of course, one has to take into consideration the unique aspects of a still developing individual where the risks may also be different. I do not know, Raquel, if calcineurin inhibitors are so special in that situation. I do think that their efficacy has been demonstrated, especially also through the transplant literature, where, of course, they're used very widely if a transplantation is needed in children and adolescents. So I do think that their efficacy and their safety have been studied quite well, actually, and so that makes us more comfortable that if we have to, we can use them and expect efficacy. So that's certainly true. And of course, belimumab has already had the approval in the adolescent and even the pediatric populations, and also with very good efficacy and safety. So I think, fortunately, for our very youngest patients, the prospects also look better and better over time.
Thank you. When I was reading the guidelines, there were two particular recommendations that I struggled to completely agree with, but let's hope you'll change my mind. When the two cases, when there is partial response or when there is refractoriness to dual treatment regimens, the recommendations, they say that escalation for a triple treatment regimen is the first recommendation, and only considering another alternative regimen if it fails. And I guess you know why I'm not completely comfortable. So if the strategy is not completely working, should we change to those that were studied to be a first strategy, or should we change completely the strategy? Ronald, do you think that that partial response versus refractory disease should be approached in the same way? And then the proposed triple regimens would be similar in speed of effect in the patient that is not quite responding?
Well, let me start by rephrasing that, because you almost got me confused as to what you meant. But what I think is that if you have a patient with lupus nephritis, and if you made a decision, or maybe somebody else made a decision to treat them with mycophenolate. They are on hydroxychloroquine, and they were also given glucocorticoids, but that was it. And now after, say, 6 months, you have to conclude that they're not doing so well. And so I think your question is, should you at this point add belimumab or voclosporin, which were both tested in a slightly different manner,
Yeah.
or should you just change the treatment wholesale, which could, for example, mean that you would switch to cyclophosphamide? And I think, yeah, I don't think there's one answer to that question, because I think it depends on so many things. The decision not to treat them with triple therapy from the start was probably made for some reasons. What were those reasons? If you think that mycophenolate is not working at all for this patient, do you have any reason to suspect that? Is there maybe an alternative explanation? Maybe the patient isn't taking it as they should, and have you checked the levels? If you chose not to give cyclophosphamide as a first time, which is probably not so much used, but maybe you already were aware of specific contraindications, or is there a reason to think that another treatment might be very particularly effective? And I think the calcineurin inhibitors, of course, have this very strong anti-proteinuric effect, which makes them a very attractive option in patients where the proteinuria is the dominant clinical manifestation. So I don't think there's one general answer. I do think your suggestion is strong, that you maybe don't want to continue on the road chosen if it's not working at all. But at the same time, I think there's also many, many other aspects to consider.
Thank you. And thank you for clarifying my doubt on this. Murray, do you have additional comments on?
No, I think Ron has clarified your doubt very well. I think what you're saying is, if they didn't respond to mycophenolate, rather than at a third, would you switch to something else? Like, well, you don't, now instead of rituximab, even with the 42% response rate, you might go to obinutuzumab or something, or cyclophosphamide, the Urolupus form, and then wait with that double therapy and not add a third one. That is one approach. The other approach to say is, if mycophenolate is giving you a partial response but not a complete response, then let's go to the classic third therapy, and add that on. So I think it depends on the nature of the initial response. Is it nothing at all, so we should change the mycophenolate, or is it partial and we should add one of the others?
Yes. Thank you. And I was asking you about, how do you think that the guidelines should be changed? When should the guidelines should be revised? Since even after written obinutuzumab study came out, so how do you think that the guidelines should be tailored with specific medications there, or with specific drugs there, or using a general triple therapy as you want to, and not completely switch the therapy for the future? Ronald, how do you think that a good guideline for lupus nephritis that does not need to be updated every year or every 6 months could go for that?
Also, first of all, I don't have any objection to how ACR does this, and they're doing a good job, I think. But the fact of these guidelines of recommendations by large professional organizations are they have a built-in delay, because when you start the process, you have to set a date, and then you have to do the process with this large group of committees and with individuals, and then you have to have it percolate through the system. So you're always going to be a little bit behind the curve, and that happens especially, of course, in a field that is moving very, very rapidly. So I think I don't want to say that the ACR should do something different, and I'm much more involved, of course, in EULAR processes, and they're similar. And I think, EULAR does its best, and we all have to keep doing that. But at the same time, as practitioners, and especially also in the academic field as sort of the practice those who articulate the practice, we have to always say that, okay, yes, but there's new developments. And of course, we have to also embrace the new developments. We can't just close our eyes to them because they're not in the guideline. So let's just keep on doing the best we can based on all the evidence, including the guideline document, but also what has happened since then.
Murray, do you have a comment?
I think Ron's absolutely right. But we should continue what we're doing now. But let me tell you, it won't be 10 years before the next revision, because what's on the horizon now is mind-blowing. You know, from the whole CAR T-cell story, and now we're getting CAR T-cell with dual targets, BMCA and CD2019. And we're getting telitacicept, which is both the APRIL and BLIS markers. So, I mean, you know, double hits, new drugs. I think so much is happening so quickly that we're going to have to look at this earlier than 10 or 12 years next time. And I think the guidelines might look very different from what we have today based on what we're seeing now in the research field. It's a very exciting time.
Do you think that the other guidelines that also recommend treatments to lupus nephritis, like the KIRGO ones and the EULA ones, even so, do you think, Murray, that they differ only because the studies on lupus nephritis were not all available when they wrote the guidelines, or do you think that these differences between the international guidelines are due to something else? So do you have any comments on that?
Well, you know, I'm not sure they're so different. You know, the EULAR guidelines came out and I was a cheerleader. I thought this was very brave of them. You know, there were no studies. These were expert opinions, and they actually recommended triple therapy, you know, and so without studies. Now, the KDIGO guidelines, my God, the studies, if you read that paper, you need 3 days to get through that paper. It's, but in essence, they're not very different from the ACR guidelines that have been published. So I think everybody is saying it looks like combination early versus sequential therapy is the way to go. I think they've all said that in one way or another.
Thank you. So, Ronald, any additional comments on these? Do you think the differences are relevant or not?
I think the differences are in part subtleties and have to do also with methodologies that are chosen to get to these recommendations. But there are some points where serious and well-meaning and well-intentioned and very intelligent experts can disagree, and that's sometimes also reflected. So I think, and then I think it's fair to have the debates, and those serve as a starting point. These documents do serve as starting points for serious discussion.
Do you have, Ronald, additional comments on how the guidelines could change our practice?
I hope that for many of us, the guideline does not change practice, because we've already included the insights that have led to the guidance into our practice. That's what I hope. But I do think the realistic answer is that, of course, for many of us, that's not always possible. And then we also run into issues like what was mentioned earlier, the reimbursement issue. And then having the guideline is, of course, a very powerful tool in getting the reimbursement. So I think it will change the practice of practice, the practicality of practice, whereas maybe our own understanding of what the practice should be like wasn't going to be changed so much.
Thank you. Murray, any final comments?
Yeah, I agree with Ron entirely. And I think the major, I mean, most of us have adopted or are in the process of adopting these approaches, but we can now use these recommendations to our payers and say, look, the world believes this is what we should do. How can you not fund it? So it's good to have them now in writing.
Thank you so much. Murray, And Ronald, thank you so much for joining me today to discuss the updated ACR Lupus Nephritis guidelines. To our listeners, we hope these discussions have helped you gain more of an understanding of lupus and developments. Please look at the show notes for more information on the update ACR Lupus Nephritis guidelines. Thank you so much for listening. We hope you enjoyed the podcast. Please leave us a review, which will really help us in reaching as many of your colleagues as possible around the world. Join us again next month for more discussion key issues in the management of lupus.